Thank you very much for your participation. Thank you really so much. So we are going to present to Rodrigo Muñoz. He is a medical oncologist focused in cutaneous tumors and sarcoma. He was the past president of the sarcoma Brazilian group, and he works obviously in the Hospital Sírio-Libanês in Brazil. So, Rodrigo, thank you very much for your participation. He's going to talk about novelties in localized disease. Thank you, Rodrigo.
Thanks, my friend. Thanks, Javier, for the kind invitation. I'm delighted to join you here today. So I'll start sharing my slides, and over the next 20 minutes, I'll talk a bit about novelties in localized disease. So as Matias mentioned, I'm a clinical oncologist based in São Paulo, Brazil, and these are my disclosures. So this is the ground that I intend to cover over the next 20 minutes. What is our standard of care? Novelties regarding systemic therapies, novelties regarding disease monitoring, and of course, what we expect that are going to be novelties in the years to come. So this is a very relevant discussion for a quite significant proportion of patients. After all, 78% of patients with GIST are diagnosed with localized disease, and not a quite significant proportion as well will undergo discussions regarding adjuvant or at least neoadjuvant systemic therapies. And these are the guidelines that we have today, suggesting that we have different moments to discuss either adjuvant or neoadjuvant systemic therapies for localized disease. As of today, we're going to offer adjuvant imatinib for patients who present with high-risk localized disease. But for those for whom an R0 surgery is not expected or considered feasible, of course, a short course of neoadjuvant imatinib can also be discussed and continue after surgery if an R0 or R1 resection is achieved. And our standard of care was defined some years after imatinib was incorporated into the systemic therapy of GIST. This story began with ACOSOC Z9001, which was a randomized study which had a somewhat permissive inclusion criteria. So patients with GIST greater than 3 centimeters, and it's important to recall this was back in 2007 to 2009, who were also CD117 positive per IH, were randomized for 1 year of imatinib at 400 milligrams or placebo for a primary endpoint, which was recurrent-free survival. And in the most recent update, with a median follow-up of 74 months, there was an increase in recurrence-free survival. So indeed, the study met its primary endpoint with a hazard ratio of 0.6. However, no significant gain in terms of overall survival. However, if we focus a bit more on high-risk patients and analyze a subgroup of individuals with GIST greater than 10 centimeters, a more clear-cut benefit was observed with a hazard ratio of 0.29, which was statistically significant. And indeed, since then, our risk stratification schema and patient selection has evolved over time. We started with only size as a criteria, we added mitotic rate, then primary site, and more recently, in a better structured way, also tumor rupture. This is only a small example showing the quite significant prognostic impact in terms of both mitotic index as well as tumor size. So patients with very high mitotic count or just measuring more than 10 centimeters indeed have a much poorer prognosis. And this is the risk stratification regimen, that schema that we use today in terms of size, mitotic count, and also take into consideration the primary site. And we have other tools that can assist us in daily practice, including nomograms that are open and available for clinical use, some of which are already AI assisted, and take into consideration the factors that I just described. What we still don't do in terms of clinical practice is to incorporate the molecular aspect in terms of risk assessment. So indeed, the mutations are not the same in terms of prognosis, and particularly patients with KIT exon 11 deletions or KIT exon 9 mutations have a much poorer prognosis, and we do need to improve and incorporate this language. And bringing this risk stratification for clinical trials in terms of patient selection, indeed, URTC 62024 already focused more on high and intermediary risk patients, randomizing those patients to 2 years of imatinib or placebo. And once again, we could appreciate a gain in terms of recurrence-free survival that was lost over time. So at 5 years, there was no clear benefit from imatinib, meaning 3 years after treatment discontinuation, and no gain in overall survival. However, our standard of care in terms of adjuvant therapy is defined by this clinical trial, the Scandinavian Group 18 or AO study, in which 908 high-risk patients, and high risk was defined by the presence of tumor rupture, or the 10 rule, patients with greater than 5 centimeter GIST or greater than 5 mitosis per 50 high-powered fields, or greater than 10 centimeters in size, or greater than 10 mitosis per 50 high-powered fields, randomized for 3 years of adjuvant imatinib at 400 milligrams a day, or 1 year of imatinib at 400 milligrams a day as the control arm based on the ECOSOG study, stratified according to the type of surgery, R0 without rupture or R1 with rupture, for a primary endpoint, which was recurrent-free survival. And this is not a novelty anymore. We had the most recent update published in 2020 with a median follow-up of 10 years, showing a statistically significant improvement in terms of RFS, with an absolute difference at 10 years of roughly 12% and a hazard ratio of 0.66 with a p, which was statistically significant. And with a better selection of patients and a prolonged duration of adjuvant therapy, so 3 years versus 1 year, indeed an improvement in overall survival was shown, with a proportion of patients alive at 10 years of 79% of those treated with 3 years of imatinib versus 65% of those who received 1 year of adjuvant imatinib, with a hazard ratio of 0.55 and a p of 0.004. So in terms of our standard of care, which are our conclusions and not so much novelties? So in high-risk patients, imatinib 400 milligrams for 3 years remains our standard of care. However, recurrence rates after treatment discontinuation remain high, which of course leads us to question the curative intent of this approach, despite the survival gains in the 3-year imatinib study. Longer treatment intervals may be necessary in high-risk patients. And of course, there's no consensus in terms of the use of molecular characterization for patient selection, but definitely, and I agree with Sebastian, specific subgroups need to be considered separately, and patients with PDGFR D842V or wild-type GIST needs, those patients need a different approach. So now, addressing the novelties that we have in terms of systemic therapy, of course, I mentioned some of those questions that need to be answered and that begin to be answered. Now, if we look into specific subgroups in the Scandinavian study, we cannot appreciate a quite significant gain in terms of survival for patients with KIT exon 9 mutations or those with rupture or tumor spillage upon initial surgical procedure. And if we indeed look into tumor rupture in the 3-year study, 73 patients, 20% of the sample, had tumor rupture. And this is a quite striking adverse significant factor. Only 20% of those patients were recurrence-free at 10 years in comparison to 55% of patients without rupture. Many of those patients could be salvaged upon recurrence. So in terms of overall survival, almost 60% of those patients were alive at 10 years. But if we look into the specific patient population, we could not appreciate a significant improvement in terms of either recurrence-free survival or overall survival with the use of 3 years of imatinib, making us question whether prolonged treatment for this patient population would be a potential solution. However, if a breakdown was made in terms of molecular background, indeed patients with tumor rupture and yet a KIT exon 11 mutation had a quite significant benefit from 3 years of adjuvant imatinib, highlighting the importance of really performing molecular profiling in this patient population. Another specific subgroup that we start to have more clear data includes patients with GIST KIT exon 9 patients. This is a retrospective series of 185 patients. 71% of those patients with KIT exon 9 mutation were treated with imatinib 400 milligrams a day. 30% of those patients received imatinib at 800 milligrams a day, and using both propensity score matching and inverse probability of treatment weighting to adjust for confounding factors, we could not appreciate any significant improvement, increasing the dose of imatinib for this specific patient population. So we cannot really extrapolate the somewhat limited data that we have from advanced disease to the adjuvant setting, as we cannot show a clear benefit of increasing the dose of imatinib to 800 milligrams for this patient population. And yet another big question that remains to be answered is whether prolonged treatment durations really can translate into improved outcomes. These are the results, not so new, from the PERSIST-5 study, which was a single-arm phase 2 study, including 91 patients with both intermediary and high-risk GIST, at least 2 centimeters in size, and at least 5 mitosis per 50 high-powered fields, or non-gastric GIST greater than 5 centimeters. And we had no comparator arm. This was a single-arm study, yet prolonging treatment duration, although not for everybody, only 51% of the patients indeed completed 5 years of therapy, was associated with a quite striking recurrence-free survival and overall survival. 90% of the patients treated in PERSIST-5 were recurrence-free at 5 years, and 95% of the patients were alive at 5 years, really suggesting that there's a role for prolonging treatment duration. And more recently, the Imatinib study addressed the same question. So in this recently published study, patients with localized GIST undergoing R0 or R1 resection after 3 years of adjuvant imatinib were then randomized for 3 additional years of imatinib, so 6 years, versus treatment interruption, so 6 versus 3, for primary endpoint, which was recurrence-free survival. This was indeed a very high-risk population, so we had almost 50% of the patients that had a GIST greater than 10 centimeters, 12 to 15% had tumor rupture, and in terms of the molecular characterization, the majority KIT exon 11, close to 7% KIT exon 9, and a few patients with PGFR alpha mutations. And indeed, in the whole cohort, extending the duration of the adjuvant therapy was associated with a statistically significant improvement in terms of survival, with a hazard ratio of 0.4 and a p of less than 0.005, specifically for patients with an estimated risk of 35 to 70%. In this patient population, the hazard ratio was of impressive 0.08. However, some of this efficacy was lost in very high-risk patients, in patients with an estimated risk greater than 70%. The hazard ratio was of 0.68, however, not statistically significant, and we could not appreciate a significant gain for patients with tumor rupture, indeed highlighting that this is a very high-risk population. However, beyond adjuvant therapy, of course, some patients may demand neoadjuvant approaches, and in this setting, evidences are quite limited. There's a lack of randomized controlled trials, and for this patient population, we still rely on individual-based decisions and multidisciplinary assessments. Of course, we do have some data in the literature. This is a study that was published already 13 years ago that divided patients who were CD117 positive in 2 groups. Group A, patients with a primary GIST greater than 5 centimeters, and patients with recurrent and metastatic GIST, so not really a very homogeneous patient population, that were staged with a PAT bomb baseline, then received 600 milligrams of imatinib for 8 to 12 weeks in the neoadjuvant part of the study, underwent surgery, and then subsequent adjuvant imatinib for a total of 2 years. And indeed, the treatment was well tolerated, and for a somewhat high-risk population, indeed, the progression-free survival and overall survival intervals and numbers were not disappointing. If we considered only patients with primary GIST, so group A, almost 57% of those patients were progression-free at 5 years and almost 77% alive at 5 years, suggesting that preoperative or neoadjuvant imatinib is feasible. This is another phase 2 study from Japan and South Korea that included only patients with primary GIST greater than 10 centimeters, a total of 56 individuals that were treated with 6 to 9 months of neoadjuvant imatinib at 400 milligrams, then surgery, then adjuvant imatinib for at least 1 year, for a primary endpoint, which was the rate of R0 resection. Of course, if the patient progressed within 1 to 3 months, this patient was discontinued from the study. And it's important to highlight that almost 90% of the patients completed at least 6 months of neoadjuvant imatinib. Those reductions were necessary in 26% of the population, and quite significant activity was demonstrated with an objective response rate of 62% with neoadjuvant imatinib and a disease control rate of 100% using RECIST criteria, and an objective response rate using CHOI criteria of 98% with the same disease control rate, with most of the responses concentrating in the initial 6 months. So most of the patients achieved the best response within 24 weeks, 63% of those patients, and an additional 15% if we prolong therapy until the 36th week. With quite significant and impressive results, a 2-year overall survival rate of 98%, including 89% of the patients who were recurrence-free at 2 years. We have additional evidences from small subgroup analysis, retrospective studies, and small prospective studies, suggesting indeed that neoadjuvant imatinib can be considered for patients with locally advanced GIST, large GISTs, and following, of course, a multidisciplinary discussions. However, many questions remain. What's the ideal interval for surgery? How to monitor this response? The optimal duration of adjuvant therapy according to the neoadjuvant response, and the role of molecular characterization and treatment pairing in the neoadjuvant setting. And we also have novelties in terms of how we monitor this disease and the response to therapy, particularly for patients undergoing neoadjuvant therapy. PET is a very important tool. We have here 2 examples showing very early metabolic responses that can really complement the molecular characterization in terms of assessing the sensitivity to neoadjuvant therapy. And of course, the incorporation, as Sebastian mentioned, of additional tools, including ctDNA. We may have some limitations in terms of shedding, but indeed for many patients, especially high-risk patients, and of course, metastatic patients, but this is not the focus of the discussion, we can identify circulating tumor DNA, highlighting that in quite a proportion of patients, we can add this to in terms of following the disease. However, in many scenarios, this still needs validation. So as of today, I would summarize the role of ctDNA in GIST with the following considerations. It's still too early to consider ctDNA in terms of screening or early diagnosis, and the same for follow-up or assessment of MRD. Many of those patients are non-shedders, and we do need to validate this in a prospective format in order to incorporate this into clinical practice. The same applies for staging and risk stratification, and in order to guide systemic treatment decisions, as Sebastian mentioned, but we are a bit more forward in those 2 specific scenarios. However, the molecular assessment is already ready for prime time and ready for clinical use. And in the INSIGHT study, for example, the pre-screening is conducted based upon a liquid biopsy. And of course, we expect novelties in the years to come, including considerations about molecular analysis for neo and adjuvant treatment, a clarification in terms of the optimal approach for patients with KIT exon 9, the potential role for neo or adjuvant avapritinib for patients with D842V, whether we should consider tumor rupture a synonym of advanced disease and potentially treat those patients indefinitely, and of course, whether even longer treatment durations are going to be useful, imagining an IMAGIST-10, and of course, waiting the results of the Scandinavian group study of 5 years versus 3 years that could potentially set a new standard of care. Thank you so much.
Thank you, Rodrigo. Thank you very much for your talk. So we preserve the questions to the end. And so for the second and third talk, we will discuss after the next talk that will be in charge. Jonathan Trent, he will talk us about the novelties, new treatments in advanced disease.
Hi, everybody. I'll share my screen. Okay, thank you. Thank you, Javier and Matthias, Isabel, for inviting me to speak on this important topic. So we've had already some review, but I just really like to emphasize that GIST is a very common sarcoma, and that it is it's really the prototype for oncogene-driven cancers in terms of not only the phenotype of the cancer, but also the treatment of the cancer. Unfortunately, metastatic disease, as Sebastian mentioned, is very common in patients with GIST due to late diagnosis, due to difficulty making the diagnosis, and other factors. Just as a review, these are the common sites of mutation, mostly exon 11, but we can't forget, as Rodrigo mentioned, exon 9 is a little bit different in terms of our approach and also the biology. And then the rare mutations in exon 13 and 17 as primary mutations. Exon 13 is one of the common resistance mutations, but in the primary setting, the primary mutation is a different mutation. It's not V654. And is in fact sensitive to Imatinib, even though it's only a few base pairs, a few amino acids away from the resistance mutation. This is a sensitive mutation. In fact, patients with primary exon 13 mutation can in fact develop secondary resistance mutations at V654 as a point of confirmation. Imatinib, the other important thing about this oncogene driver is that is the fact that it in fact drives multiple phenotypes of the cancer. We know that there are that cancer cells have all these hallmarks of oncogenesis that have been published multiple times. Many of these factors can be driven by KIT mutation, as shown on this slide, which is different than the carcinomas. Most of the carcinomas have multi-step tumorigenesis where each of these phenotypes might be driven by different genes. So KIT is a very potent oncogene driver in the setting of the interstitial cell of Cajal, which is critical because it's also an Achilles heel. Imatinib and all these other kinases we've heard about are very effective at inhibiting KIT, and in fact can block a number of different phenotypic characteristics of the GIST cells that have all been proven now in vitro and some in patients. Just as a reminder, these are the drugs that are that are commonly used. These are the drugs that have been approved by some of the regulatory authorities around the globe. And Imatinib in frontline is by far the most effective. Whether or not any of these later line drugs like ripretinib will challenge frontline therapy is doubtful because of the number of patients needed to see an increase in efficacy. And then these other agents are effective, but in the 6-month, 5-month range, avapritinib 4-month range, other than the PDGFR D842V, where avapritinib is very effective and is approved by several authorities, regulatory authorities. Now, this slide is just to point out the GIST subtypes. When GIST was first coined and we were talking about TKIs back in the early 2000s, we talked about GIST. Now we know that GIST is comprised of a number of different molecular subtypes. And we saw the differences between exon 11 and 9 and the resistance mutations and D842V. But another non-trivial subgroup, maybe as many as 10% of GIST patients, maybe even close to 20% of gastric GIST patients have a tumor that's driven by Sdh deficiency. And so this has been a tough tumor to treat. We'll show some recent breakthroughs, but I'd like to give kudos to the LifeRaft group who's here on the call today, because they've invested a lot of time and effort in a better understanding of Sdh-deficient GIST. This Sdh-deficient GIST can be diagnosed, in fact, with immunohistochemistry. We generally do mutation testing to confirm it, but there is a very good immunohistochemistry. Maybe some of the pathologists could chime in on their experience with it later. But recognizing this is important, as the other more rare subtypes such as RAF, FGFR recently described, TRK fusion GIST we see, and possibly some other subtypes. As far as a wild type GIST, it's becoming clear, at least to me, that likely doesn't exist. The term is still used today. We don't like the term, but it is used by some. I don't think it really exists. There may be some rare examples. The likely explanation is that we haven't found the mutation yet. This is just an example of D842V, very resistant, other than development of avapritinib, which is a huge breakthrough for these patients because they had no other treatment options. Sebastian already showed this, so I'm not going to dwell on it. This is a patient with a TRK-driven GIST. You can see in the bottom panel this large tumor that decreases in size over time from left to right on a TRK inhibitor such as larotrectinib, entrectinib, etc. And we'll spend let's discuss a little bit about the SDH subtype. And so Sdh-deficient GIST really was defined from an NCI clinic started by Lee Hellman and others. And at that clinic, hundreds of patients with so-called at the time wild-type GIST, in other words, GIST without a KIT or PDGFR mutation, were evaluated. This is largely Sdh-deficient GIST, but there's also some NF1 patients at the clinic. And through NCI work in the lab, these tumors were evaluated in terms of their epigenetics and also gene deletions. And it was found that about 2/3 of the patients, so for the patients that had loss of SDH expression by immunohistochemistry, about 2/3 had deletion of the SDH gene, and about 1/3 had epigenetic repression of SDH transcription and production of the protein, translation into the protein. So SDH can be lost in either of the two ways. If SDH is lost, it's important to understand if it's epigenetic or if it's deletion of the gene, because deletion of the gene can be hereditary in the so-called Carney's triad and Carney-Stratakis syndrome. The loss of SDH at a germline can be hereditary, and that could impact siblings or other individuals in the family, and would require referral to medical genetics for counseling, etc. Importantly, at a cellular level, SDH is found in the mitochondria and converts succinate to fumarate. And when SDH is lost, succinate builds up and can travel to the nucleus and impact certain enzymes and inhibit certain enzymes in the nucleus that are involved with gene expression. And this can lead to increases in DNA methylation and a hypermethylation phenotype, and can result in loss or decreased expression of an important gene called MGMT, which increases sensitivity to DNA alkylators such as temozolomide, and can lead to cell death. With this, and this has been described largely in in pheochromocytoma, paraganglioma, where temozolomide is used, and taken advantage of this vulnerability. Jason Siklik, who gave me this slide and has done a lot of this work in his lab. And in fact, he led a clinical trial where patients with Sdh-deficient GIST were treated with temozolomide, 85 milligrams per meter squared, 21 days on, 7 days off, had CT or MRI every 2 months and continued to progression. And this is one example that was presented by his group of a 22-year-old man treated with a metastatic Sdh-deficient GIST involving the liver at the red arrow. And then on the right, you can see on 8 months of therapy that the tumor has substantially decreased in size. This patient had a SDHB mutation that led to loss of SDHB and loss of the SDH complex, and benefited from therapy. So the clinical trial has been done and in fact showed a positive response. He reported a 20 to 30% response rate for patients with Sdh-deficient GIST. The other trial that has been now completed for Sdh-deficient GIST patients is regorafenib. This is a pan-FGF receptor inhibitor. And this is based on laboratory data that loss of SDH can lead to overexpression of both FGF receptor and FGF the ligand, creating an autocrine-paracrine loop for the GIST cells. And that was susceptible to FGF receptor inhibitors in vitro. This was confirmed in an animal model. This led to a national study for regorafenib and Sdh-deficient GIST that was completed at 5 sites. And at the time of this presentation last year at CTOS, Priscilla Merriam showed a 17% partial response rate. Since that time, some of the PRs that you can see on the slide and stable disease have actually, some of the stable disease have become PR. And now it's looking like the response rate is around 30% for Sdh-deficient GIST patients. So these are two great treatment options that really were not available or not known even just a few years ago. So subsequent follow-up trials are planned with additional FGF receptor inhibitors, since regorafenib is not going to be continued, and temozolomide combinations. I've not heard of a temozolomide regorafenib combination study, but that would be compelling, I would think. Now, we spent some time talking about ctDNA. I'll just share some of our experience at our site, showing that resistance mutations are most commonly KIT exon 17 and exon 13. These are important, as Sebastian pointed out, from this early publication in 2004, from 11 tumors that were studied, identifying the ATP-ADP binding site at V654 as the common mutation site, as well as the activation loop in this patient 820. And Sebastian also showed this grid that continues to evolve over time. This is based on in vitro, in vivo experience, and is certainly is certainly evolving over time as we gain more knowledge and experience with these inhibitors. Really, the take-home point from this whole heat map is that sunitinib is by far the most active drug at exon 13 and exon 14 resistance mutations. The other inhibitors shown here and others that we're getting experience with, not sure that any of them are going to be any better than sunitinib in this study. And sunitinib is not very active at exon 17, 18. So the trial, the INSIGHT trial that Sebastian showed, is really stacking the deck against sunitinib, and patients with known exon 17 resistance mutations are being enrolled on the study. And as long as sunitinib doesn't exceed its efficacy, the study, I would think, would end up being a positive study and could change the way that we're approaching our GIST patients in terms of ctDNA. So I'll share with you an example. This is a patient of mine that was 52-year-old, KIT exon 11, primary resistance, responded to Imatinib. At progression, she developed this lesion at baseline on the far left and was put on the Avapritinib trial. This is right when we were just starting to do ctDNA, and so we didn't really know the impact of the different mutations. And so this patient progressed rapidly on Avapritinib, as you can see in the middle panel. This is like an 8-week scan. So this patient had very active disease. She had probably 15 liver lesions and was in fact had borderline altered mental status. We had to admit her to the hospital, and we ended up getting her ctDNA test back, and it was an exon 13 resistance mutation. So we were able to get consent from her husband to administer sunitinib in the hospital, and within a week her mental status cleared up. She had a durable response to therapy on sunitinib when she had massive progression on Avapritinib. So this would fall in alignment with the heat map I showed earlier. And this is a patient that was actually on the far panel, was referred to hospice and called me for a second opinion. We did ctDNA testing, found that he had an exon 17 resistance mutation. He had regorafenib before, but we at that point in time, a ponatinib trial was ongoing, so we decided to try it off-label. Treated the patient with ponatinib, and he had a very, very durable response that lasted nearly 2 years on ponatinib for in his like 6th line of therapy. So ctDNA can be very powerful, and I honestly believe it's going to be one of the biggest advances that we see in the future, even beyond the drugs. And so this is IDRX. Other drugs are coming in the pipeline, though, than the ones that we've been talking about. IDRX-42 also was presented at ASCO last year, and this showed that the majority of patients respond to this therapy. Some of the responses have been very durable. In fact, there's patients that have been on this IDRX-42 and 5th line therapy for more than a year. So it's a very potent drug. There's some hint that it may be particularly effective against exon 9. But this is data is evolving, and we're going to hear more about it at ASCO and CTOS. Response rate for these patients in 2nd line was 43%. Now, the PEAK study is combining bezuclastinib, an exon 17 resistance mutation active agent, with sunitinib, a KIT exon 13 resistance mutation. And we started the study in phase 1 and really didn't have any idea of the tolerability or the activity of the combination. And in the phase 1 study, we put 18 patients on the study, and one of the patients on the phase 1 study responded and continued on therapy for about 4 years. And so this looked very promising. And it was surprising to me that patients were telling me that the combination bezuclastinib plus sunitinib was as well, if not better tolerated than what they recalled being on sunitinib alone. Now, the PK doesn't support bezuclastinib reducing sunitinib levels in any significant way, so the levels are maintained. But this is a very tolerable combination from the phase 1 study. I can tell you my experience. The PEAK study randomizes patients to bezuclastinib plus sunitinib versus sunitinib alone. The trial is already done accruing. It has all of the patients. We're still waiting on the final data, which we hope will come out maybe in the late summer, early fall, as far as the final results. But there was a lead-in study due to change in formulation, and I can share some of that data with you as it's in the public domain. And this is data from the lead-in study where the formulation and packaging was changed of bezuclastinib. And again, showing the majority of patients have some decrease in tumor size, and a fair number had met the criteria for partial response. And so this does seem to be an active combination. Whether or not it's going to be better than sunitinib, I'm not sure. Again, it comes down to how sunitinib performs. Is it going to perform at the 6 PFS or the 9-month PFS? And so we'll have to see those results hopefully late summer, early fall. There's been a lot of talk about antibody drug conjugates, and they're used in several types of cancer, including breast cancer. We don't have any in sarcoma yet, but there's a clinical trial, phase 1 clinical trial, looking at an antibody drug conjugate against protein that's prevalent on sarcoma cells called UPARAP. But there are also antibody drug conjugates being developed against other targets such as KIT. And that study is a phase 1 study that's is available at several sites for refractory GIST patients around the world. And so this is a reminder that the GIST molecular subtype really determines the therapy. And this is a list of some of the new clinical trials that are ongoing. Grayed out are the ones that have completed accrual and are really not available. But this is a very, very good time for GIST patients in terms of new drugs, new availability, in terms of new KIT inhibitors, and also in terms of adding drugs to KIT inhibitors to make them more effective, such as DCC-3116, that's a autophagy inhibitor that should enhance apoptosis induced by ripretinib, combining ziftometinib, an oral menin inhibitor, with imatinib, and the power of ctDNA is being evaluated in several studies as well. I'll end there. Thank the sarcoma and GIST team and be happy to answer any questions.
Thank you, John. Very, very nice talk. And so it's time for questions from the audience. We have 10 minutes for questions. So be free to raise your hand or to write down the question through the chat. So it's a good opportunity for make questions in front of these leaders.
Go ahead, Nadia.
Well, I was writing in the chat, but anyway, it's quicker. So my first question is, what do you do in practice now with patients with a high risk GIST without capsule rupture? Do you routinely prolong imatinib, or you stop at 3 years? It's a question for anyone who wants to answer.
Rodrigo?
So I believe I addressed a bit of this controversial topic during the presentation. The truth is we have no straightforward answer. Indeed, for those patients with a ruptured capsule who are exon 11, I treat for at least 3 years, but if well tolerated, I believe that we have, at least in terms of natural history, some support to potentially prolong this indefinitely. And indeed, this could be a disease that is considered advanced disease when there's a ruptured capsule. But in terms of guidelines and the evidences that we have, we only have support to treat those patients for 3 years. But would I consider prolonging that in terms of natural history and the preliminary data that we have? Yes.
I was referring to those without capsule rupture.
Oh, those
because
without.
Because with capsule rupture, I think we have data suggesting that prolonging it's better. But without, we have now the data of the Imatinib study, so we have even prospective data suggesting that prolonging imatinib could at least prolong relapse-free survival. We don't have yet data on overall survival. And I know in certain places, I think in the US, it's quite common to prolong adjuvant therapy. But I would like to know what you do in your places.
So for patients with very high risk, greater than 10 centimeters and greater than 5 to 10 mitosis, I always discuss prolonging that until, used to be until 5 years, now potentially 6 years. But we still lack, at least in many Latin American countries, access to do that. So we have constant issues in terms of approvals and access, limiting treatment duration to 3 years. But I definitely would consider.
Yeah.
Okay, Rodrigo, in the same line, I want to ask you if you consider is there any non-gastric GIST that adjuvant therapy is not indicated?
So in non-gastric GIST, I would rely on the molecular characterization. So would I perform upfront NGS or molecular profiling for those patients? Yes. And I believe that's even more relevant for non-gastric GISTs. So for example, D842V or wild-type GISTs, I would consider not offering Imatinib.
Okay, Rodrigo. And which is the opinion of John, if there is any group of GIST patients in the adjuvant setting that adjuvant therapy is going to be forever?
I agree with Rodrigo. It's a conversation we have with patients. If it's certainly rupture, definitely we do it forever, but indefinitely anyway. But in greater than 10 centimeters, small intestine, super high mitotic rate, it's worthwhile having that conversation with a patient.
Okay, Javier.
We are very committed with obviously with LATAM countries, in the sense that new clinical trials will be settled on different countries in different sarcoma subtypes, including obviously GIST. But now, what would be your recommendation when we have no access for clinical trials and we have really use the standard of care in advanced disease? What is your recommendation? Is cabozantinib is another kind of tyrosine kinase inhibitor for progressing patients?
John?
Yeah, we're using, sometimes we're using cabozantinib. It's active against exon 17 resistant, and there's pretty good data on cabo in GIST. So we're using cabozantinib probably most commonly there's not a great exon 13 inhibitor unless, IDRX or one of these other approaches, the ADC or the Nube drug. If one of those is good at exon 13, that's a huge need, because sunitinib is by far the most potent and really the only exon 13 resistance inhibitor. We have lots of exon 17 resistance inhibitors. And then, like Sebastian mentioned, we're seeing emergence of these cis APAL, and there's not really any way to target those very well at all. So that's a huge need also.
Yeah, I think, thank you. Yeah, I completely agree. I think it's a good idea that maybe RAF-Life group and the GIST working group within CellNet will display a map of the sites where GIST clinical trials have been activated in Latin America and in the USA. So maybe it's interesting to know that, because sometimes some patients can be referred to these places for when the treatment has been exhausted in our place. So I think it's interesting to have this information as well. So this was a parenthesis. Thank you. Other questions?
Yeah,
I believe there's another question from Nadia to John, right, in the chat.
Yeah. Nadia says, when do you think that genotype will be incorporated in risk calculation?
Well, I'd like to hear what Rodrigo, his experience has been. But from my experience, it's not that potent of a risk factor, because it's 557, 558 deletion is probably the most aggressive GIST, and it correlates very well with mitotic rate, high mitotic rate. So I don't know if it'll be incorporated like the mitotic rate, anatomic site and size, but it should definitely factor in as a predictive biomarker of response.
The question very important is adherence, because Rodrigo mentioned before that adherence to therapy is an issue in GIST. PERSIST trial showed that half of the patients do not use the treatment as physician said. So how can we get some strategy with patients to monitor therapy or to monitor the adherence to therapy? Which is your opinion from Brazil, Rodrigo, and which is your opinion, John, in the USA?
So adherence to any chronic treatment is always a challenge, and this applies not only to GIST or oncologic therapies. If you treat hypertension, you're going to face the same issues. So highlighting the risk that we're trying to prevent and fighting is something always important. If we look into PERSIST-5 data, only a relatively small proportion of patients discontinued therapy due to indeed adverse events. Most of the patients discontinue simply based upon patient's decision. So really having this open discussions is important. And it's also important to highlight that the tolerance to Imatinib at 400 milligrams is pretty good. Of course, if we try to increase the dose, then we're going to face more adverse events. If we go to 800 milligrams, then it becomes quite a significant challenge in terms of bone marrow toxicity, edema, fatigue, and so on and so forth. But perhaps establishing a parallel with adjuvant therapy in breast cancer, which also brings many symptoms, really having this continuous assessment and discussion and positive reinforcement is something that I always do with my patients, particularly for those with very high-risk features that we may go beyond 3 years, up to 5 to 6 years, are those patients who are going to receive therapy indefinitely.
Okay.
I agree. Adherence to therapy is certainly it's a global phenomena. It's the same as Rodrigo said in the US.
Okay, Gloria, you have the hand rising. Go ahead.
Yes. Nice to see you again. So I have a question to Dr. Joe. It's about the ACH patients. In this case, with Sdh-deficient patients with GIST, there is a particular pattern for metastasizing in these cases. And after that, after first time of treatment, what is your preference to use in second and third line? In that cases, thinking about Latin American patients who don't have resources for clinical trials, what would be the best preference for second and third treatment in those cases?
Was that for Sdh-deficient GIST?
Yes.
Yeah, so the data is good on temozolomide and regorafenib. What we were doing before that was regorafenib or sunitinib may have some capability to at least slow down the disease. Not really any published durable responses, but we've all had some patients with Sdh-deficient GIST who may have had some slight decrease in size, at least stability with a drug like regorafenib.
Okay.
And about the pattern of recurrence, there is a particular pattern of recurrence in Sdh deficiency GIST.
Yeah, they can involve lymph nodes. So when the patients have surgery, the surgeons that I work with typically, they don't do a formal lymph node dissection, but they evaluate lymph nodes intraoperatively very closely.
Okay.
They often can be as well multifocal, right? So that's also something peculiar to Sdh deficient.
Thanks.
Okay, Javier.
So I think we should finish here. Thank you very much, all the speakers and all the attendees for this successful webinar focusing on GIST. Thank you for the advisory patient groups as well that were able to connect. So we will continue working on GIST and other sarcoma subtypes within our network. So thank you very much for your time and take care. So we are in touch. To the next. Bye-bye.
Bye. Thank you.
Bye-bye.
Bye-bye.